Dr. Pan, happy to have you on our Invisible Reality cast. And for those know, Dr. Pan is a Chief Division of Geriatric and Palliative Medicine, Care Medicine. You're a designated institutional official and director of graduate medical education. You're the author of an amazing book, which is The Exit Strategies. We're happy to have you and get from your knowledge.
Thank you so much. I'm really excited to be here to talk about this very important topic.
Yes. Well, not many people like to talk about it, but I'm glad you are.
It can be a taboo topic, a very serious topic. People are afraid. They don't know the words. I just experienced way too much of it. And I feel like end of life is still part of life, right? So
That's true.
instead of fearing it and avoiding it, we should really just embrace it and maximize it.
That's true. So a question come to my mind, like how was your experience in both geriatric medicine and palliative care that shaped your end-of-life care?
Yeah. Yeah. I think it's all started. I went into geriatrics because I was very close to my grandmother. I think that's a very common story. We had a special bond. She gave me my Chinese name. It's called, which translates into happy heart. So I
Yes.
really credit her with giving me this optimistic outlook. And when she passed away, she was in a different country. I was here. I was in medical school, and I never really got to see her or say goodbye. And I think that's always been a regret of mine. There were a lot of circumstances. And I think that I want to use palliative care, end of life care skills to help people heal. Use that time as a time of healing and reunions and being able to say the things that really are important. Unlike what happened with me and my grandma.
Yeah. Yes. So how do you approach, since you said it's like a kind of taboo like subject,
Yeah.
so how do you approach families and patients in the discussion of end of life care while they come from different backgrounds?
Right. Yeah. Here in New York City and in Queens, which is the most diverse county of all of the United States, we have people coming from all over the world. So if we think that these conversations are tough in English, now try to do it in a different language over an interpreter, right?
Sure.
So I think the first thing is we all have to get educated because knowledge is power. And that's part of the reason why I wrote the book, to be public facing. Of course, anyone can read it. I think it would be very good for medical students,
Yes.
PA students, nursing students, everyone. But public facing so that the public can become more knowledgeable through the
Oh,
stories and become willing to ask their doctors about end of life care. And I think that once somebody starts, it gives permission for other people to talk about it. And at the same time, we have to educate our workforce, our doctors,
yes.
nurses, physician assistants, whoever, to really also be able to approach and open that topic.
So if you don't mind me asking, how many years have you been in end of life care? And
Oh, more than 30.
okay.
Yeah.
Okay. And it's like we lack training.
Still, it's getting a little bit better. I think medical schools have some more. The PA schools, nothing.
Well,
And I think that one anecdote that I really remember very vividly is that before I started doing this kind of advanced directives and goals of care communication training in the hospital where I work at NYP Queens, residents used to call me and say, Dr. Pan, come and see this patient. The family's here. Come and talk to them. So I would go upstairs and then I would literally see the resident run the other way. Like, okay, the family's over there. The family's over there. And they were running in the opposite direction. And I'd be like, where are you going? Come on, let's do this together. Oh, I have to go do a discharge. And they ran away. And now after the training, they call palliative care counsel and say, Dr. Pan, I need you to see this patient for like complex pain and symptom management, but don't talk about goals of care because I want to start that discussion first. So that's night and day.
Yeah, that's great.
Yeah.
Can you discuss some innovative approaches you've implemented to improve the geriatric and palliative care education?
Yeah. So I think that education, again, truly important, and make it in a fun way. So for example, one of the things that we're doing now is called GoCom, and it stands for Goals of Care Communication. It's a workshop. And where we have small group training, we limit it to between 8 to 12 people so that people feel comfortable speaking out and having conversations. If you do it in a lecture hall in a large group, a lot of people become very shy and they don't want to say anything. Right? So we do it in a small group. We do a little bit of teaching and then we do a drill. Like, okay, how do you discuss prognosis? Let's do the drill and use the, the skill that we learned. And we try to get people to be very brief. A lot of times doctors, when we get nervous, we start talking a lot, using terms that nobody understands. So we spent 5-10 minutes talking with the patients and the families. Big surprise, they didn't understand much. And then we say, well, I already spent a lot of time, but they don't understand anything. They must be in denial. So we start labeling the patients. Okay, we have to be very simple and very brief when we give information. And then the other thing is, in addition to just talking and conversations and drills, we also do simulation with standardized patients. So these are actors who play standardized patients. It is very realistic. And our trainees, they say, wow, I didn't think that simulation was going to be realistic. But the second I got into it, I was like, oh, this could be a real encounter. And so they really get into kind of the role play, which is fun.
Yeah, that's awesome. So what advice would you give to medical students, residents who are interested in pursuing this career in geriatric or palliative care medicine?
Yeah. I mean, geriatrics and palliative care, I'm trained in both. They're a little bit different. They both require a lot of patience and interest in focusing on patients' quality of life. Geriatrics, obviously, is age-defined. So the Medicare definition would be 65 and older. And for geriatrics patients, there are patients who are very healthy, and then there are patients who are very sick. There's a whole continuum. For palliative care, it's a specialty focused on serious illness. So age doesn't matter. As we know, there are patients who are 50 years old and very sick and have multi-organ problems. There are even pediatrics patients and neonatal patients who are born with very serious conditions, right? So that's different. So in palliative care, we see a lot of end of life. That's a subset of palliative care that I find the most hard to talk about and a taboo topic in any culture. And that's why I wrote my book about it. I just wanted to get back to you about, not only for students, let's say, who want to enter the field, is this very important, but also anybody who enters any medical field. These are really foundational skills because even though we all go into medicine to save people, as soon as we step into medicine, we learn that patients die. Some patients die no matter how much we try, right? And we have to have the skills to be able to treat their symptoms, to guide them, to emotionally support them and their families, to prepare them for what ifs, and to protect their dignity.
I think it's very important to teach that early in medical school because I speak for myself. Like I was surprised, I was shocked.
Yeah.
When I started working. So yeah. It needs a lot of courage.
Yeah.
I think emotional courage.
Yes. Yeah. Yes. Emotional courage is one thing, and preparation, right? Yes. When we do training, we're supposed to be supervised. So if our faculty are not trained, they can't really supervise as well. I remember when I was a sub-intern in medical school, and I formed a close relationship with a patient. He was an elderly gentleman with a lot of vascular problems. I didn't think he was going to die. Nobody talked about advanced directives back then, And lo and behold, one day there was a code and it was him. He went into cardiac arrest. We all ran upstairs and we worked on him. We tried to resuscitate him. He died, right? Now looking back, I'm not surprised. But back then, there was nothing about prognostication, no resuscitation, preferences, code status discussions, what patients wanted, nothing. Everybody got coded. So he died. I locked myself in the on-call room and I was sobbing. I just couldn't stop. I was so sad and upset with myself that we couldn't resuscitate him and save him. Then my resident knocked on the door and said, Cynthia, the family's here. Do you want to go tell them? I was like, no, you go tell them. And I continued to cry. And that was very traumatizing for me, right? So I always look back and say, how could it be better? So number one, we need to prognosticate. We need to be able to look at a seriously ill patient in front of us. And based on what we see in our clinical judgment and calculators that we have, what's their prognosis? Are we looking at years? Are we looking at months, weeks, days, hours? What are we looking at? And we have to be able to prepare ourselves, our nursing staff, our teams emotionally, and prepare our patients and families, because when time is short, maybe they have things they need to do. Maybe they don't need to be stuck in the hospital.
That's true. That's true. So you talked about your grandma, and I think that's what inspires you to write the book, Exit Strategies. So
yeah, my grandma inspired me to go into geriatrics. And the exit strategies was many of my patients. Even though I've seen thousands of patients, I used to be a hospice medical director. So I saw a lot of patients who are at the end of life. I used to make house calls, and I got to know a lot of them, as well as in the hospital and nursing homes. And there were so many scenarios. I guess I accumulated that experience. And yet, when I see a new patient now in the hospital doing a consult, it's like Groundhog Day. You know that movie? Like the same thing keeps happening every day after day. So I feel like things haven't changed that much, And that's the reason why I wanted to write this book, because things have to change a little bit more quickly. We're living in an aging society across the world. People are living longer, and that means that they're accumulating more chronic medical problems. Nowadays, we're not admitting like 60, 70-year-olds. We're admitting 90, 100-year-old patients. They're not only coming in with pneumonia, they're coming in with pneumonia on top of heart failure, COPD, CKD, dysphagia, a little bit of cognitive impairment, like a million medical problems. So we have to be able to treat them and give them the dignity that they deserve by first asking, at this point, with all these medical conditions and coming into the hospital, what's the most important thing to you, right? In a realistic way, and be able to support their families to have that conversation.
So what are the questions you hope that the readers will get from the book?
So I think the first thing is get the book. Don't be afraid. Courage, like you said, emotional courage to open up the book, and maybe taking like a lighter approach, even though this is a serious topic, to be able to maintain a sense of humor, because there's some funny stuff in there. And some patients, they have a great sense of humor. Like I remember one of my patients, I was trying to start an advanced directives discussion with him, and I didn't really know how to do it. This was earlier on in my career. So I was going around in circles, and he noticed it. He said, "Doc, just be honest, be straight with me, And I said, "Yeah, I want to talk about end-of-life wishes and what ifs, so that we're all prepared and I know what you're thinking." And he goes, "Sure, Doc." He goes, "I never met a person who left this world alive. So let's just talk about it." So I was like, "You're true, Yeah, you're right." And then another patient who was also very smart, he had respiratory failure from like 3 different reasons. And he had a healthcare proxy, and it said it was his daughter with a name on it. So even though he was alert and with it, he had capacity, but because he was on the BiPAP for respiratory failure, everybody was running around trying to find a daughter to speak to. Meanwhile, we should have been speaking to him. But we couldn't find the daughter. So we ended up going to speak with the patient. And, we asked him, like, "Where's your daughter?" Everybody's trying to find her. And he goes, "Oh, yeah, the nursing home tried to hide it from me, but I found out that she died."
I remember reading.
So then we said, "Well, we have to talk with you." So we started talking to him. He said, "I don't want to be on machines, no intubation, none of that tube stuff." So he made that very clear. And then we asked more questions about, what if in the future something happens where he couldn't swallow? Naturally, would he want a feeding tube? What about his kidneys? Would he want dialysis? And he said, "Oh, let's talk about that later when that happens." And we got very nervous. We said, "Well, by the time something like that happens, you may not have the mental ability to talk to us. So then what? We have to get it from you now." So he said, "How about this? Let's just keep it simple. If I have my mind, ask me. If I don't have my mind, don't do it." Which is brilliant, because right now the default status is if you don't have your mind, we do it. We do everything. We try to keep you alive. But no quality of life sometimes, right? So he changed the track. He switched the track. So he said, if I don't have my mind, then don't do any of it, which is brilliant.
So, in your experience, have you seen any patient that went to like feeding tube, everything, like they are out of their mind and you did everything? Did they come back to their normal self? Not normal, but like a good quality of life, kind of? Have you seen any?
Have I seen any? I can't say that I've seen any. Maybe less than 1%. Mostly we see patients who get intubated and then cannot get off the breathing machine, the ventilator. So they end up getting a tracheostomy. They're hooked up to the life support. Then they get a feeding tube because they're really not awake and alert to swallow. Then they go into kidney failure, so they get on dialysis. Yeah. So I call that the triple threat. You vent, peg, dialysis, really don't know what's going on. And one of my patients I've seen many patients like that because, we have a chronic ventilator unit. And it's like patients are there, they don't know why they're there. And families feel like they made the wrong decision, but they have the heart to now turn back the clock. And they often tell me, if I knew this was what was going to happen, I would never have signed a consent for the trach. Never. But now it feels like pulling the plug. And even though that's the reaction in our hospital, I have to say, I'm proud of that because, we've had hundreds of palliative extubations, which means in a compassionate way, disconnecting the patients from the ventilator and allowing them to die naturally and giving the families kind of, relieve them from their suffering also. And that's a privilege that we have in this country, that we have laws that permit that. In many other countries of the world, that would be illegal. And doctors would not be able to do that. So we have that privilege in this country.
In your experience, the most misconception about end-of-life care, like people have?
Well, one is, as the past president of Robert Wood Johnson Foundation said, death is not an option in America. So we all live forever. Right. Which we know, of course, is not true, right? Everybody kind of knows that there's a life cycle. And there's a Chinese proverb all about that, 生老病死, which means you're born, you age, you get sick, and you die. A lot of religions believe in the life cycle. But because it's sad to lose a loved one, I think, especially when someone is younger, because it's sad to lose someone, it becomes emotionally overwhelming. And you feel overwhelmed or sad, to even think about it, to go there. So we stop ourselves from crossing that line. And then we lose opportunities because the patient may have a lot to say. The families may want to say things, but nobody really has the permission. So I think giving permission to talk about this topic. So if someone wants to take the book and say, look, I just read this book, Exit Strategies, and it's great because it gives people permission to talk about a taboo topic, then that would be great.
Yes. And one of the misconceptions that I had in mind, and you made it clear in the book, like I got it from the book, that end-of-life
Thank you for reading the book.
Oh, yeah, I finished it. I love it. So one of the things that I thought that end-of-life care doesn't go to home. Like you have to be hospitalized. I didn't know that.
Yeah.
Like you can have end-of-life care, but at your home, at your like comfortable bed, of like your comfortable environment.
Yes.
To be honest, many people might not know that.
Yeah, you're so right. You're so right. Like hospice care in the United States, the goal is to keep patients at home. So the vast majority of hospice care is at home. I was equally surprised when I started doing hospice visits. And I went to so many patients' homes, and it was amazing because, to see somebody in their own environment being comfortable. But a lot of people still think that hospice is going to a place. Like if you say hospice in Spanish, like if you translate it into hospicio in different countries, Spanish-speaking countries, it may mean an orphanage or a place for people who are mentally unstable. So it has a poor connotation. And in some countries, the standard of healthcare is that if somebody is that sick at the end of life, then they stay in the hospital. So different countries and healthcare systems are different. But here in the United States, we have the opportunity to go home with hospice care to get the support that the patients need.
That's amazing because I don't think anyone would want to stay in the hospital in their like end of days.
Yeah. I've asked a lot of patients about that. I would say in my experience, anecdotally, about 5% of the patients would want to stay in the hospital. And about 95% of the patients would want to go home. Why are some of the reasons that they don't want to go home? One, because they have no home, right? If they're homeless or if they're renting from the landlord and the landlord is telling the family, we don't want people dying here because that's bad luck. So now the patient cannot go home. Okay. So there's some of the reasons. Sometimes the patient is too sick to be transferred to go home, even though that's their wish. So, and then there's some people who actually really love the hospital. They wouldn't mind staying in the hospital all the time.
I stayed in the hospital for preterm labor for 2 months, and I was going crazy. Like
Yeah.
the machine beeps,
Yeah.
everything. Like you're in a closed room, so
Yeah.
I don't think there are many people who like to stay there.
No, the majority don't.
Yeah. So, how can healthcare providers better support patients and families in end of life care decisions?
The education piece, getting some education, and that goals of care communication course is only 4 hours. And I think that's what I would consider to be the BLS, right? There's BLS, basic life support, and then ACLS, advanced cardiac life support. So I would consider a 4-hour course like that to be BLS. It's designed for all frontline clinicians so that they can open the door to that conversation and knowing how to open the door. And then if they encounter difficulties, that's when they call a palliative care consult. They could also call a geriatrics consult, depending on what's available in their hospital to assist them. And also to really think about what matters most in life, right? Because at the end of life, time is short. Like we think, oh yeah, I don't have time. I'm running out of time to do this and that. That's just on a regular day. But when we're really talking about end of life, time is really short. It's quite limited, right? If I knew I was going to die tomorrow, I wouldn't be here with you on this podcast because I would have other things that I would want to do, right? So many patients have plans. They have things that are on their list that they would like to do, but they don't get to do it because their doctors never got a chance to tell them or didn't know how to tell them that time was short.
I think it goes even culturally. Even if the doctor talked to them, the culture, the family, it's not a comfortable like conversation or like subject to think about. Like I'm dying, I have to finish all of that.
Yeah.
Unless we make it, as you said, like we make it an open subject and celebrate the end of life.
Yeah.
Celebrating 1 year old baby who didn't do anything, celebrate a 90 years old.
Yeah. Celebrate their life, their accomplishments, the legacy, the families that they created, you know, the history that they created. And I think it's about being comfortable with being uncomfortable. I just want to share a thing because over Thanksgiving, you know, this past Thanksgiving holiday, I heard about many deaths. Some were expected, some were unexpected. The holidays can be pretty tough for people. And I used my Thanksgiving to talk to my family members about each person remembering someone who has passed away, who made a significant difference in their lives. And we all wrote down something. And it really made us connect much more closely. And it did get emotional, but that's okay. I mean, it's okay to be emotional, right? And it's hard for me to say that. Like, it's weird for me to say that because I'm Chinese American. I'm brought up to be very reserved, don't show any emotions. But I think through palliative care, I've learned that emotions are okay. We're a human being and we need to acknowledge and accept our emotions. And it worked out very well, that Thanksgiving conversation. And it was emotional, which helped us connect even more. But what happened was I also posted this conversation on one of my social media. And one of my college classmates from Harvard, she said, as a etiquette columnist, she's a columnist about etiquette for some paper or something. She said, I strongly admonish you from doing something like this, that Thanksgiving is about family connections and you should not be forcing people to have a conversation such as this. So I strongly advise against it. And it just like made me realize this is the reason why I wrote the book, because
Yes.
Like the etiquette columnist is saying, don't talk about it. So that's what they're saying. It's bad etiquette to be talking about this topic during the holidays. Well, I don't think it's bad etiquette. I think it's emotional and it's connecting.
Why is bad to face reality?
I don't know. But exactly, that is my question, to face reality. But if that's what the etiquette columnist is telling people, then I don't think that's a good sign.
Well, but that's why we need more of like this podcast and people reading the book. I got emotional with the book.
And that's okay.
Yeah, and I was thinking of my parents. I was thinking of I have an autistic brother, so I was
Me too.
thinking of him. And yeah. It's hard.
Yeah.
I'm very close to him. Like I'm very attached to him,
Yes.
and it makes me sad to think that one day he's not going to be there.
Yeah.
But at the same time, we need to talk about it.
Yes.
So
Totally.
we can bring their wishes to life.
Right. And advocate for them and know what's important to them. I had my brother also, he has developmental disabilities. And even though he's a grown man, his psychological age is about 8, 9 years old. And he's not really able to talk about advanced directives, like complicated medical stuff. But he's able to appoint a healthcare proxy. He knows who he likes and trusts. He knows who he doesn't like or doesn't trust. So he's able to distinguish that. And that's really important.
Yes. So another question is, what role does cultural competence play in providing effective end-of-life care? And how can providers providing this?
Yeah. So that's a really great question. It's very intersectional, right? The intersection between end of life and cultural competency, cultural humility. So we want both. Cultural competency is really getting our knowledge about certain cultures that we're not familiar with, at least knowing the basic information and healthcare decision-making norms and things like that. And then cultural humility is to not stereotype, use that information, go to the patient and say, oh, Mrs. X, I read about this in your culture. Does it apply to you? And just check in instead of stereotyping. It's very important because different cultural norms, for example, in the Asian culture, I've studied this a lot. When you talk about advanced directives and what's important to the patient, it's better not to ask directly, which is the New York State standards, clear and convincing evidence, right? The patient has to apply the situation to themselves. So if I ask a Chinese American or a Korean American elderly and say, oh, if something happened to you in the future, like if you had a stroke and you couldn't eat, would you want a feeding tube? That would be very offensive because now it's like, oh, you wish me to have a stroke? That's not respectful, right? So people are not going to respond to that. The better way is to come from the side, and there's published literature research about that, to say, Mr. X, I see a lot of sick patients. Many of them had strokes or dementia to the point that they can't swallow by themselves. Some people choose to have a feeding tube. Some people choose to eat naturally with comfort feeding, small amounts of foods that they like. What do you think about all that? Right? So to ask their opinion would be more respectful. And then whatever they answer is their opinion, that pretty much would be what applies to them because it's their opinion. Right?
Yeah. And I remember reading in your book a story about your father too.
Yeah. So that was about
very
Yeah. So I think that's the other thing to remember is that because it is a tough topic and not generally accepted, well, when you first open the conversation, try to give it a little context, say why you're opening the conversation. You can use the book as an excuse. You can use President Jimmy Carter, who's been on hospice for more than a year, close to 2 years at this point, okay? Use some excuse to say why this is important. I care about you, therefore I want to talk about it. And then if the reaction is not positive the first time, it's okay. Don't be scared. Just expect it to not go well, right? Because it's not a familiar conversation.
Yeah, I'm just imagining if I opened this subject with my father, he would say, now you wish me to be dead,
Exactly.
Yeah.
Right.
Yeah.
So
that's what.
Yeah. So much to the point that one of the New York Times cartoonists, Ross Chast, she wrote a cartoon book about this topic, how she tried to have these conversations with her parents. And the title of the book it's a cartoon book. It's called Can't We Talk About Something More Pleasant?
I struggle.
Yeah. But the first time, if it doesn't go well, then it's okay. You can try the second time and just know that you have now opened the door.
Yeah.
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 And give them permission that this is an okay topic to talk about.
So can you share an example of particularly impactful patient story that shaped your approach to palliative care?
Yeah, I have like so many impactful patients.
To write another book, please.
How much? Some have, some taught me to have courage, like we talked about. Some taught me to have joy and a sense of humor. Some taught me to really, connect with them on things that are important to them. So, for example, I had a patient who had advanced head and neck cancer, and she had multiple surgeries and radiation treatments, and to the point that she had a tracheostomy, but she was awake and alert. The trach was eroded, so you could see like half the trach from an open wound. And she was cachectic, even though she was being artificially fed. And she was in bed and appeared depressed. So I went to see her, and she just kept looking out the window. She really seemed like she didn't want to talk to me. I asked her some questions, and it was just, like, seemed like I was bothering her. And then I sat down and I said, so, like, tell me, what did you do for a living? And she kind of perked up, and she's like, oh my God, I used to be a hospital attorney. I was a workaholic, and work was everything, to the point I didn't even have a family. And now look at me. I can't work. I'm useless. And that was why she was just so depressed. She was just laying in bed, not being able to do the work that she loved. And I said, I kind of understand how you feel, because I'm a workaholic myself, I spent a lot of time in the hospital. And then after that, we kind of connected. So I think connection is very important. Finding out things about the patient where we can connect. I've had patients who are Spanish speaking, and I would ask them, like, where are you from? Because I grew up in South America. So if they say they're from Colombia, I'm like, colombiana and paisana, Then we talk about like what places in Colombia, and I would try to get their recommendations about what cities to visit. So try to find something that you can connect with the patients about. And I had another patient who was like the one that we were talking about before, trach, vein, peg, dialysis, out of it, not conscious. And I was speaking to his family, and the family actually told us that he was a famous jazz musician, and they gave us his name. So I looked him up, and for real, he had albums. So for the longest time, to honor him and to really, I don't know, just to make myself feel better about seeing him in the situation that he's in, I would just be playing his music all the time for a while. And then after some time, his family, on the third hospitalization, came back to me and said, you know what, we don't think that this is a quality of life that he would consider acceptable anymore. We tried our best. We thought he would come back. He's not coming back. He's just getting worse and worse. I think at this point, we would like to liberate him from the ventilator so that he can go in peace. And they ended up taking him off the ventilator. And he passed away because he was really being artificially maintained. He would have died.
Well, how can medical schools, since we said there is no training in medical school,
there's some training, not enough.
Some training.
Yeah.
Yeah, but I don't think all medical schools have that
variable.
training.
Yeah.
So how can schools better integrate palliative care and end-of-life care in their curricula?
Yeah. I think there's the reason why I say things are better is because now LCME is requiring end-of-life curriculum of some sort in medical school. It's very general. It doesn't say how long. So if you had one lecture, that could count. If you had a whole rotation, that could count. So it's very variable. And now I'm thinking so I think that it's really up to each medical school having the faculty to design something. There's probably not one curriculum that works for everyone. But they at least have to do something. and not only medical schools, but also nursing schools and PA schools and respiratory therapy schools because, speech language pathology schools, because all of us end up seeing these patients. So my next plan is I would like to take my book and approach some medical schools. If you know of any that you want to, introduce me to, that would be great. And because I think some of the stories will be very pertinent learning material for medical students.
Well, I know the school I graduated from. I can email them and see, but it's internationally, which is what we want. Like, we want that to be international.
Yeah. Nowadays, on Zoom, everything is possible. That's one of the silver linings of the pandemic.
Yes, that's the silver lining. I think Zoom was the only company that didn't go bankrupt.
Yeah. But now Zoom is not, I don't know, it's not doing as well as I want them to.
Yeah, but it's still, we got used to it. Like, we're using it more.
I love
using
Zoom.
it more.
Yes.
Yeah. So what specific communication skills should be emphasized in your opinion, in training of healthcare professionals?
Yeah.
For the end-of-life care patients?
Yeah. That's a great question. I think the first thing is really coming from respect and curiosity. Forming a trusting working relationship with the patient by having a connection. Because the reality is that patients nowadays, they see a lot of doctors, nurses, people, and it's not really nice to have a serious conversation like this without really knowing them a little bit, right? So establishing a trusting relationship, and that can be done very quickly, like asking the patients what kind of work they do or what brings joy in their life. A lot of older patients will say, my grandchildren, my family, or my travels or something. So just establishing something that forms a relationship. And then to ask them, what have your doctors told you about your medical condition? Because we also live in an ageist society. So when we have older patients, a lot of doctors start talking to their families to the point that the patients may not even know what's going on. And that's not good, right? We need to ask them, what have the doctors told you? And would you like to participate in your own medical decision-making? Would you like to know what's going on? And that's very cultural too, because in many cultures, it's not patient-centered, it's family-based collective decision-making. And we have to respect that also. So we have to understand the family dynamics. And then if the patient is willing to understand their prognosis and their medical condition, then for us to convey it to them in a simple way. So we recommend a way that's called headlining. So like a newspaper headline, right? This is what's happening. This is what it means. Not like a whole organ system-based, long dissertation that we learned in medical school. We don't want to do that.
So can you give me an example? What do you mean by it?
Yeah.
Yes.
So for example, if a patient who has COPD and respiratory failure who's on home oxygen, who's been admitted now for the third time, and you're worried, right? Instead of going on and on about the anatomy or the physiology or whatever, to just say, Mr. Smith, this is your third admission from emphysema in the hospital, and that makes me very worried that your function and quality of life may not be the same in the future, and you might need a lot more help. So this is what happens, and this is what it means.
Okay, in simple words, no military.
Right. In simple words.
So you talked about the training. You said we train 8 to 10 people, and then you do a drill.
Yeah.
So how can simulation and role-playing exercises be effectively used to prepare students for the real-world end-of-life care and conversations or scenarios, let's say?
Yeah. I think any training is better than no training at all. Simulation is very useful because if you're going to make mistakes in communication or you're going to try different communication strategies, it's probably better to make those mistakes with a fake patient, I guess, with a standardized patient rather than a real patient. Although in my experience, real patients are very forgiving. As long as you show that you care and that whatever you're saying is coming from a good place, they will forgive you. But the other good thing about simulation is that we'll provide feedback right away. So anytime you want to train and get better in communication, you want to prepare, you want to do the actual communication, and you want to get real-time feedback, right? Real-time feedback means right away, not 2 months later when you don't even remember what happened, right? So in a simulation situation, you can go for, let's say, 3 minutes of an encounter. Then I will be the facilitator. I'll time you out and say, time out. Okay. Then I'll say, how did that go for you? They'll say, oh, that went well, or that didn't go well. I was stuck or whatever. And then I could give them a little bit of feedback. And then their group peers, the other 8, 9 people, can also say, oh, you did well by doing this specifically. Or next time, maybe you could try something like that. So that's very useful to get feedback from 360 degrees.
So how many years have you been doing that training?
This type of training, I got a grant. Luckily, I really have to thank the YC Ho and Chiang Foundation. And since 2019, we've been doing this in some way, shape, or form.
Yeah, so it's around 5 years.
Yes. Yeah.
And have you seen any, like, do people enroll willingly, or you guys, like, would you recommend it to some of the students or like residents?
That's a very good question. Yeah. So we find that attending physicians, people who are in practice already, tend to not do it, not want to do it, probably because they're very busy and they have a lot of, clinical pressures. But there are some who are very willing to do it. We don't want to force people, because when you mandate or force people to come to training sessions like this and they really don't want to come, they come with an attitude. And that can be disruptive for the group, right? It would be disruptive for the clinical learning environment. The people who really embrace it are people who are in their training. So like residents and PAs and students, because they're really in a learning mode. And with them, we can build it, work with their program director and build it into their curriculum, or what they have to learn anyway. So right now we're training all the interns in internal medicine every year in our hospital. And that's one of the examples that I showed you before, that before they used to run the other way and say, you talk to the family. And now they embrace it and say, please, you don't start. I want to start and try it out. And another anecdotally, difference that we're seeing is that the interns or residents, because they're trained, when they're rounding in the coronary care unit and they see a patient who's very sick from end-stage heart failure and heart disease, they're having the whole conversation and they make a plan for hospice and everything. And then the cardiologist, the senior attending, comes and says, oh, no, you guys don't know what you're doing. Call palliative care. So they call palliative care. And I look at the note and I said, well, you guys did everything. Great job. But the attending doesn't believe them because the attending never got trained. But meanwhile, the residents did it. They took care of it. There's no need to call palliative care.
So you said internal medicine, just the residents and PA and everyone in internal medicine. Do you think it's important to address end-of-life training in other specialties like pediatric, OBGYN? Because end-of-life doesn't mean you have to be old.
No. Right. End of life is everywhere, right? Because it's part of the life cycle. And that's why the palliative care boards is open to OBGYN, emergency medicine, surgery, pediatrics, family medicine, radiation oncology, like all of these, because it's cross-cutting. I used to have one of those surgeons in the hospital. Every time he saw me, he's like, oh, how come your service is not here 24/7 or around the weekend? Do you know that there are people dying on the weekends? And I said, excuse me, people die everywhere. And it's every doctor's job to take care of those patients. It's not only palliative care's job. I mean, I have a very small team. But meanwhile, we have a lot more surgeons in the hospital than palliative care people. So, I'd be happy to show you the skills and share with you some of the communication strategies. But you're going to have to, face that because it's everyone's job.
So what are the benefits of interprofessional education in palliative care training? So what do you think the benefits would be?
Yeah.
And for
training is critical. That's a basic foundation part of palliative care and of geriatrics. So in the hospital, I think it benefits everyone, and it certainly benefits the patient and the family. We have physicians, we have nurse practitioners, nurses, social worker, pharmacist, chaplain, because when someone is seriously ill, it's not only the medical issues, right? They also have, there's a concept called the total pain concept. It was coined by Dame Cicely Saunders, and she was the founder of the hospice movement in the UK. And total pain is the concept that a lot of times when a patient says that they're in pain, we think that it's physical pain. But in fact, it could be spiritual pain. It could be financial pain. It could be social, psychological, emotional. It could be a lot of dimensions. As a matter of fact, they did a study at Calvary Hospital, which is a Catholic hospital in New York. And they asked patients who had pain and said, is your pain physical or spiritual or emotional, or just like categorize it according to the total pain concept. And there was a significant percentage that has spiritual pain, right? What does that look like? It looks like if they're religious or spiritual and now they're terminally ill, they might have doubt in their faith and say, God, why did you do this to me? Why did you give me lung cancer when I never smoked? Are you abandoning me, right? That's an existential spiritual pain. Or some people might go the other way and say, now that I have this, I feel more connected to you, God, and I'm stronger in my faith, and I want to, redeem and make up for things that I didn't do in the past. So it could go in many different directions.
And how can medical education address the emotional and psychological challenges in healthcare providers facing dying patients?
Yeah,
Because it's an emotional
yes,
career.
Yes. And that relates to your previous question about why it's important to say, let's have social workers or chaplains, because they're really trained to handle emotional situations, whereas medical doctors are not trained to handle medical emotions. I would say probably nurses, social workers, chaplains, everybody is better at handling emotions than doctors, because we don't get training in that. We get training on cognitive information, like just the facts, right? So that's why teamwork is really beautiful. And I learned a lot from my teams about emotional acknowledgement. So there's a really good mnemonic. Maybe you have heard of it. It's called NURSE. And it's a mnemonic that's used to acknowledge emotions. So the N stands for naming emotions. So if you're having a conversation and the family starts crying, then that's when you want to stop and say, I can see that talking about this is very emotional. Let's just pause for a moment, because emotions are very natural and we want to embrace our emotions, right? And then to say like an understanding statement, like, I can't even imagine what you must be going through right now. It's a lot. It's very tough. And I give you a lot of respect that you're all here working as a family together, even though you didn't always get along, but now everybody's here. So really paying attention, paying respect, and acknowledging the emotions.
So, Dr. Pan, thank you so much for your time, for your knowledge, and I really recommend the book. I was just planning to write a review.
Thank you. I would highly appreciate that.
Yeah, I will today. Trust me. I have the book right now in front of me.
Thank you. Thank you.
What I wanted to say that we need training. We need a special curriculum in communication with dying patients and their families.
Yeah.
As a physician, my husband is a dentist. Is a dentist too, but he's like, I don't want to see end of stage or like cancer patients because I don't know how to emotionally with them.
Right.
And I think it's very important to have this curriculum in healthcare professional schools.
Yeah.
Not just physicians.
Yes,
not just
everywhere. There's a very good website called Vital Talk. And it's run by Tony Bach. He's a physician and oncologist and palliative care. And they have short videos about how to manage specific situations. So I think that's a good resource for a lot of people, how to manage emotions. And I think that, we all have to learn it, right? Managing emotions, that's part of life. We're all going to encounter it. It's going to make us better doctors, better dentists, better healthcare professionals. And you never really know what we can do. I remember 9/11, when it happened. A lot of my colleagues and I, we were all trying to help in some way. And I remember two of my classmates from medical school. One was an ophthalmologist. One was a psychiatrist. They were good friends. They said, let's get together. Let's just go and see how we can help. They didn't know. They're like, I'm an eye doctor. What can I do? I'm a psychiatrist. What can I do? There's a lot of trauma and burns. Who knows what's there? But they went there. And because of the smoke and burns and stuff, a lot of people had eye problems. So the ophthalmologist got to do a lot. And a lot of people were in shock and they didn't know what to know, all the emotions. And the psychiatrist got to do a lot. Meanwhile, they thought they couldn't do anything. So you just show up and you never know what you can do.
Yes. Before we end this, I read the book. You had a very different perspective than regular physicians on death, dying people. You're like, end of life is part of life. So they need to live.
Yes.
They need to have their wishes. And another thing you said, many physicians are happy when they don't see their patient. That means because they are getting better. But
Yeah.
when you don't see your patients, you're not happy because that means they are gone already,
Yeah. Right.
right?
Yeah.
Yeah, I've never thought of it. It's a different perspective.
Yeah. And also, so I think the life part, like I see patients who are at the end of life very often, right? But at the end of the day, when I go home, I'm not thinking about dying. I'm thinking about living. Because the lesson
Yes.
that I take from that is that life is short. We better maximize every day. Carpe diem, right? Make every day count. And because I see what happens, right? People could be well one day and the next day, you never know what happens. So make life count. And for the people who are at the end of life, help them feel valued. Don't,
Yes.
also don't give
Also,
ageism. Like people are living longer now. I see a lot of people, families, right? Trying to tell their 90-year-old mother or grandmother to say, oh, you're 90 years old. Don't do this. Don't do that. Let us help you. Don't. So now you're taking away their ability to do things. And
yes.
that is called learned helplessness. So when somebody
Yes.
learns to be helpless and feeling like they cannot contribute and there's nothing more they can do and all they need is help, that makes them lose the will to live. Because a lot of people, we all want to contribute and help in some way. Once you take that away from somebody, then they feel like they're no longer needed. And that's a terrible feeling.
Yeah, thank you so much for the live lessons you gave us. Thank you. Thank you for your time. And I hope we can have you again on Invisible Reality.
Thank you.
And I recommend you write more books.
Oh, thank you.
But
And
yeah, because you have many stories. You have a lot to give.
I have a lot of stories. And I really love the title of the podcast, Invisible Reality, which this is one of them, you know?
Yes. Yeah.
Yeah.
That's true. Thank you so much again.
Thank you.
And have a good day.
Have a beautiful day. I wish you an amazing day.
Thank you so
Okay.
much. You too.
Bye.